Good afternoon, everyone. Real pleasure to see all of you here, and I want to thank you for coming today. But before we begin, I want to say a special thanks to Marie Jo Corey and to Adrian Allen for all they did to help put this thing together. So thank you very much. Because they have to deal with people like Bob Zimmerman, it's painful. So this is really a very wonderful day. Obviously, we have many friends and family and alumni here, all of whom have gathered to have this special day to acknowledge and celebrate the extraordinary career of our dear friend, Moody Wharam, and what he has meant to multiple generations of residents and faculty and patients. So I think you all have programs. So as you can see in the program, we have a number of guests who've traveled, some from far and near, to be with us and to share reflections on Dr. Wharam. Moody, I think most of them will be positive. I can't guarantee that, but most of them should be. And for my part, I'm particularly interested in seeing how the former residents, and our residents today don't have this full appreciation. I want to see how the former residents, when they start talking to Moody, I want to see just how big the underarm sweat stains will be, because I know it's going to bring back those memories, those fond memories, Moody, that you instill in all of us. I don't know how many department chairs are in here, but as people know, to be a department chair at Hopkins has very, very few perks. Very limited. One of which, though, is I can decide who gets to go first in the program, so that's going to be me today. So that's about as good as it gets. That's particularly important because I don't know what's going to happen once Raven and Zimmerman come up here and ruin the whole damn thing, so I'm going to go first. So, first the science. Well, no. So, Moody, I think, and I know I can speak for a lot of people, it will be difficult to overstate the powerful influence that you've had on many of us, certainly me, I can say that, teaching us how to expertly and compassionately treat patients, how to rigorously think about our science, the literature, how we apply it to improve the care of our patients, and how to professionally interact in a gracious way with our colleagues. And Moody, for all that, I know I can speak for everyone, myself included, we want to thank you for that. You've even shown us how to successfully and graciously maneuver through life with a first name that I still do not get in my head. But it's still very impressive, so I appreciate that. But for those of us who know Moody, this latter point, which is what I say as a joke, but really it's not surprising because when you talk to anybody, and I did talk to a number of people before today's event, some of whom couldn't join us, the uniform comments in some fashion or another really reflected in these two, that he's the consummate gentleman, he's an elegant man, and I know those to be true, because you have to with a name like that. I recently had an opportunity to communicate with a real legend in our field of radiation oncology who wanted to add some comments, Moody, for today on your professional attributes, and that's Dr. Larry Cohen, who many know was the former long-term chair at St. Jude Children's Research Hospital, who, like Moody, is one of the key leaders in pediatric oncology in this country. So Dr. Cohen wanted me to share with this audience, and now I'm quoting, Dr. Wharam's contributions to the field of radiation oncology, and pediatric oncology more specifically, have been matched by few others. In addition, Moody is the perfect ambassador for our field, and has beautifully represented it in an ever humble, sophisticated manner, setting the example of an ideal mentor and colleague. I think this is deserved high praise, Moody, for you from another legend, and it's absolutely well apt. So Moody, you've been, for many of us, I do believe, the consummate mentor and colleague. I know you know this, but I'm not sure the audience does. I've turned to you many times over the many years of our relationship together for lots of advice, for guidance on all manner of things. But the one thing, as chair of this department, I value most in you is that you are never failing. There is not anyone that I trust more than you professionally. If there was a task to be done, Moody would tackle it, do it extremely well. I would never, ever have to be concerned with the quality of your work or the reliability of your honest opinion to me. So Moody, you are truly an honorable man, and I thank you for helping me. Now, for those of you who don't know Moody that well, and for those of you who do will know this to be true, there's very few flaws this man actually has, which is in and of itself kind of bothersome. But he's a fairly frugal man. And I think, what's our relationship, Moody? 26 years. 26 years. And in that amount of time, I think I've seen him buy lunch once, maybe twice, I'm not sure. And it wasn't for me either, by the way, just to be clear. So otherwise, he'd show up with his little lunch bag packed for him by Mrs. Wharam, with those little perfectly, cut sandwiches, the little chips, maybe some fruit, the little sippy drink. And I'm pretty sure there was always a little note from Sheila in that lunch bag. And I remember distinctly when we were residents, Bob Zimmerman was convinced that note always contained some sort of risque message. But like your children, I can't even get my head around that at this minute. So I prefer to think of it as a note just reflecting her fondness for you and to tell you to pick up the damn milk on the way home. But the notion of being careful with resources is another lesson I learned from you, Moody, certainly for the department. I think we've done well because of that lesson. And though I do buy lunch every day, Moody, except my wife, who is here, does not send me a love note every day. So we need to talk about that. Oh, there you are. She does pick up the damn milk, though. Yeah, it's a good point. And that's in a text, not in a love note. But so in the end, the lessons I learned from you, Moody, about professional and personal life have been very profound, including the need to always stay focused on family. And it's absolutely true that you've always shown unwavering devotion to your beautiful wife, Sheila, to your children, Anne and Franklin and Julie, and to your grandchildren, whose names I don't know, but are beautiful nonetheless. And it's always been clear your family is the most important thing in your life, and that remains an important example for all of us who lead very, very busy lives. And thank you for that. So as I was reflecting on this day, quite honestly, and I was trying, there's a lot of lessons that you have given to me, a lot of gifts you've given to me, and I was trying to get my head around what would be if I could articulate the one most important one. And I was thinking about that. I came somehow into my head of a quote from a French philosopher, Bruyère, that I had seen many years ago in college. And the quote is not, it doesn't perfectly do it, because I think if we added one word to this quote, it would be exactly what it is I learned from you. So if you allow me, I'm going to read the quote and then provide that modification. So Bruyère's quote is, "There are certain things in which mediocrity is intolerable. That's poetry, it's music, it's painting, and public eloquence. But as I said, if we added one word to that, it would be the lessons you taught, which is medicine. And that mediocrity in medicine is intolerable. And that we cannot tolerate mediocrity in the practice of medicine and the treatment of our patients." And Moody, I know I have fallen short of that ideal a few times, but please know I have tried. I watched you my entire career learning all the time, and have tried to emulate you practicing medicine, which, in my opinion, you are the closest thing to that ideal, the person that I've seen practicing medicine. So on behalf of my fellow trainees, your former patients, Johns Hopkins, I thank you for all of these gifts that you've given to us. You have had a truly outstanding and influential career, so thank you for that, Moody. Okay, so the rest of the afternoon is somebody other than me, which is a good thing. We thought we'd have someone who was an outstanding resident who we can claim as our own, which we love to do, to give some science and some background on Moody. And so that's Dr. Timothy Chan. And Dr. Chan is the Vice Chair of the Department of Radiation Oncology and the Payne-Weber Chair in Cancer Genetics at Memorial Sloan Kettering. He's also the Director of Translational Oncology Division and full member of the Human Oncology and Pathogenesis Program. And finally, he's the Director of Immunogenetics and Precision Oncology Platform at Memorial Sloan Kettering. And Tim's an extraordinary, please sit, Tim. I know it's uncomfortable, but when they do the Nobel Prize, you're going to have to get used to this. Tim's an extraordinary researcher and has had a number of critical observations around cancer genetics. But most recently, and I think very importantly, and hopefully something he'll talk about today, is really the genetics that underpin immunologic responses in cancer. And Tim has graciously agreed to share some of that work today, and we're really happy you're here, Tim. Thanks very much.
Hey, first of all, I want to thank Ted and thank the organizers for the really kind invitation. It is truly an honor and a pleasure to come here to pay tribute to Moody Wharam. And I was asked to talk about some science about what we do, and I thought the title here is what I'm going to talk about. But it's a little bit challenging because I wanted to merge sort of how Moody has over the years affected my thinking. He got into my head, okay? So he got into my head and it never left, right? And that's a very, very good thing. And you might ask, well, how is that a good thing? Well, then you have to also ask the question, what's a radiation oncologist doing studying immunotherapy, right? Well, it's because partly, a large part because of the principles which I picked up training with Moody and the rigor in which you ask questions about the biology and the resolve to make treatment better for patients and kids and so forth, better and better with each patient that you see. That is an unwavering pattern behind all this, okay? So this is why we ask these questions. This is why we spend all these hours. And Moody taught me how to do that when I was a resident here training with him, right? So these lessons are not like the lessons that we learn where, look at this data, let's share this data, let's write a paper. These are the lifelong lessons that actually stay with you and you impart to the next generation. So I very much appreciate you doing that. So why don't we go ahead and start just with a few slides. I'm got tasked with the serious stuff, all right, because I'm going to be a little bit serious. You got Dan here and you got Bob Zimmerman. They're going to do the roast later. So I'm going to stay a little bit serious here. But what I wanted to say basically here, just to start off, and I will admit I stole this picture straight off of the Hopkins website, right here. Very, very, very nice picture of Moody. I looked and I was like, wow, that's a great picture. I was putting this together last night. And so he has truly been a pioneer in pediatric cancer treatment and a father of modern pediatric radiation oncology. But I will tell you that this man has been doing precision oncology before it was a thing, before it was called precision oncology. And in the next two slides, I want to tell you why I am convinced of that, right? So first off, one has to know that in terms of learning how to do this precision oncology, this has come from the way in which he has taught and interacted with his colleagues. But amazingly, I think that this is probably one of the most important legacies one can leave as an academic physician, how you touch people. Now consider all the patients and kids he's given a second life to, right? This is a truly humbling experience. When I was training with him, writing notes and, setting fields, I'd never necessarily thought about that, but over the years, you begin to realize how many second lives he has given back, all right? So this is extremely important. His trainees and also his colleagues, and that's what I want to really tie the scientific talk into, is really how in looking back at what our lab has done and our group has done over the years with the immunotherapy, how we learned to ask those questions because of the rigor and intellectual thought and approach that Moody Wharam has imparted to his trainees. Sorry, this keeps on going back and forth. So Moody Wharam taught me how to treat patients with care, but to treat the disease with rigor, ingenuity, and always with a focus on how we can improve, right? Nowhere was this more evident than futzing over 2 millimeters on the CSI film, right? Like going back and forth, making it perfect. But that is fantastic. It's great because the patients do appreciate that. In reducing toxicities and maximizing cures. Now others will touch on this in the panel, but he's been a pioneering force in oncology treatment through the decades. He was among the first to actually use radioimmunotherapy for liver cancer before it was a thing, before it was fashionable, all right? Nowadays, of course, there's a lot of this stuff going around, especially with lymphoma and more recently with immunotherapy. But I wanted to put that out there because it really set a standard for feasibility that this could be done. He and Stanley Order, of course, when they were here. He pioneered, and one of the people that pioneered the optimization of both combined modality therapy and radiation therapy for vulnerable patient population. But it wasn't just that you would set up a trial or set up target a low-hanging fruit. If you guys have ever seen the IRS trials, they are a tangle of complexity. What is that complexity and why drive towards that type of precision? Even back then, it was a desire to tailor the therapy, the dose, the fields to where that tumor was. It was limited by the technology of the day. Genomics happened a little bit later, but it was an attempt to use all possible information to tailor the therapy to maximize the clinical benefit, and to ask the questions. If something didn't work, why didn't it work? If it did work, why did it work? Right. So these are the things that Moody Wharam has taught me over the years as we entered the realm of immunotherapy just only a few years ago, but which, as you guys know, is quickly becoming a new pillar of cancer therapy, much like radiation therapy. So with that, I'm going to run through some of our data. I think hopefully this will sort of tease some mental juices and sort of get some of the residents and trainees thinking about future projects so that we can further build upon what Moody has instilled in trial design and therapeutics. So what I'm going to talk about very briefly is immunotherapy so I'm a cancer geneticist and also a radiation oncologist, and I really started studying immunotherapy largely because in clinic, we amazingly, I treat, radiosurgery patients, and in clinic, I noticed that we were having many patients survive 5, 6, 7, 10 years with metastatic brain cancer. And we wanted to ask the question, going back to what Moody had said, ask the question why people are doing better, right? So we went ahead and asked the question why, and so we decided to apply some genomic constructs, and this is kind of where, this new field of immunogenomics has really was reinvigorated, shall I say. What I will say is that immunotherapy is really a different kind of therapeutic. It's unlike really a targeted compound where you sequence the genome here and you have a drug targeting something. The immunotherapy really reactivates the T cells, right? So it really, what it really does is it takes advantage of the T cell's ability to reject foreignness, right? So it really attacks things that it sees as foreign. Now, tumors by nature have mutations, and some of those mutations are going to be foreign, and this underlies a lot of the therapeutic efficacy of immunotherapy. Now, obviously, we didn't quite know that before asking these important questions. I'm going to go through some of these data very quickly, but some of the new exciting agents, there seems to be, many agents being FDA approved these days. Some very exciting studies coming from here, which I'll talk about as well. This being one of the homes of, with anti-PD-1 therapy, which is one of the major FDA approved agents on the market now for many cancers. But what we'll show you here is that this is some of the initial data with IPI showing a nice improvement in addition to dacarbazine for melanoma, and this is a recently completed trial for bladder cancer where atezolizumab, an anti-PD-L1 antibody, actually causes a significant increase in survival. Those of you that are in oncology and have been for 10 years or more will agree with me that we have not seen these kind of shifts in a long time. Okay, so these types of major shifts in survival are very substantial. However, we have a lot of challenges, and this really, I really, in going into this, wanted to sort of invoke some of the study designs that the IRS utilized and so forth, really to tease apart the biological differences to help tailor therapy. And what I will say here is that despite the fact that anti-PD-1 therapy has been, by all measures, a success, most people are not the Jimmy Carters, right? Most people do not actually benefit. And here, I've circled across different disease types the frequency of patients that actually have no response. And actually, we're not even halfway there, right? So there's a lot to do. And one of the points that I will bring up is that when you see this happen with single agent therapy, you automatically think, and you go back to the lessons of IRS, and you go back to the lessons of pediatric brain tumors, that have proven successful, like medulloblastoma, is that you must combine therapeutics at this point, but do it on a rational basis based on the biology of the disease. All right, so I will also point out here again that the 5-year data for non-small cell lung cancer here that Julie Bramer shared at AACR this year shows that the long-term survival for pembrolizumab and BMS 003 is really only about 16%. It's not that high, right? So we have a lot of work to do, and part of that is figuring out how to use standard of care cytotoxics and radiation in combination with immune checkpoint blockade. So. In line with how to approach these types of problems, this is sort of my guiding outline of how I approach things. A different biology and a different language is what we are looking at in terms of immunotherapy, and that is how I sort of draw it up here. You have the tumor cell, you have the T cell, you have all these components, the DNA of the tumor cell, the DNA and RNA of the T cell, and you have how they talk together, right? So each component, each new dialect of the language must be deciphered in order for us to maximize immunotherapy and to improve upon patient care. All right, so each of these also is dissectable using large-scale genomic technologies, which we have the luxury of being able to use now. So what do we know about who responds and who doesn't? I mean, this is very, very important because durability of this disease is actually of this treatment is actually very good. Now, I have patients in my clinic out 10 or more years with metastatic disease that are tumor-free, completely tumor-free. All right, so this is quite amazing. Never seen this before. We need to figure out why this is happening to some folks, right? Same as with rhabdomyosarcoma, you have to ask, well, do we give the same dose to paraorbital rhabdo or Bacteroides? In kids, if we give a lot of dose, it's maybe too much and really adversely affect the kids. I mean, these are the types of questions that are critical, and the questions remain the same. The technology changes over time, but the questions remain the same. So PD-1 staining, as you know, Drew Pardal, Suzanne Topalian here, very eminent faculty members at Hopkins were the first to describe this. We actually, pioneered the use of mutational load in genomic landscape of tumors, which I'll talk about. I'll touch on specific genes and the immune microenvironment. So some of you may have seen this before, but we did the simple project of sequencing people that have gotten with lung cancer that have gotten immune checkpoint blockade, and here all this is the total number of mutations in the whole exome, the whole expressed part of a lung cancer patient. These are responders and these are non-responders. Here, this is a survival curve. These are the responders and non-responders. And what you see is, as we expect, the more mutations a cancer has, the better the patient does, right? What does that mean? It means the more foreign your tumor is, the more likely when your T cells are woken up that they are able to get rid of that tumor for you, right? That is fundamentally important because for the first time, we know that immunotherapy actually targets alterations that occur in the cancer that shouldn't be there. That is your therapeutic window. So here, we had another paper in the New England Journal that I've updated for you as of 4 months ago, it was significant then, but combined now, it's even more significant. These are melanoma patients treated with anti-CTLA-4, another agent that was approved. You see these patients do very, very well, and I have these patients out a decade with metastatic melanoma. So it's quite nice. And if you have under 100 mutations, you actually don't do as well. We did the same thing in lung cancer, and what we showed was, I showed you the data from before. Here, it turns out also, and this is just a curve showing, a graph showing the total number of exonic mutations here. The green guys are the responders, and what we noticed is just two things. It's a complicated slide. We show that patients that have a lot of damage from smoking, actually do better. So that it turns out, there's a twist here with irony that if your tumor is heavily developed from smoking, you actually can do better with anti-PD-1 because they make tumors that are just really foreign looking to the immune system. And also we noticed back then that there were a lot of DNA damage repair mutations. I want you to pay attention to this part very carefully because this will have implications for application of radiotherapy. So if there are a lot of DNA damage repair mutations, what happens is there's more mutations. So we found an MSI, mismatch repair mutation here in this cohort. These patients tend to do better. So then subsequently, Luis Diaz and Jung Lee and Bert Vogelstein and Drew Pardal and others ran a very nice phase 1 trial looking at the very opposite ends, right? They looked at colon cancer and other cancers with something called MSI, which is it comes from a syndrome where you have a lot of mutations, right? Lynch syndrome. And if you have this, you have a lot of mutations. If you don't have this, you don't have as many mutations. And lo and behold, just by giving the antibody, you have much, much better response and survival just with if you have more mutations. So this was very, very nice. Now, I'm not going to belabor this, but this has been validated many times. And recently, just last week, this concept was approved by the FDA. The pembrolizumab has been approved, fast-tracked, for hypermutated tumors. The first indication is MSI, and there are a number that are following very soon afterwards once the trials report out, because there's many ways to get mismatch, to get hypermutation. So this is quite nice. I think this is the first time that the FDA has approved something because of a genetic alteration across all cancers. It doesn't matter where you are, where it is. And what's also interesting is that recently there was a large phase 3 trial with lung cancer, and this was with anti-PD-1. And what we actually basically see is that this trial was negative. This was a 600-patient trial from BMS, and when it was negative, I actually checked. I don't have any stock, okay, but I checked, and BMS's stock, all the way down. Not so good. But anyway, if you actually look at mutational load and stratify by mutational load and not by anti-PD-1, which is what other people have done, this becomes a positive trial, right? So this just converted a negative trial to a positive trial. So this is very, very good. We're starting to be able to understand why some people respond and other people don't respond in the phase 3 randomized setting, which is the gold standard of how the FDA determines approvals. Now, so at Memorial Sloan Kettering, what we've done actually is, learning the lessons that Moody has taught. I think I've sort of gone a little bit nuts on this. So what happens is we sequenced about 2,000 patients that have gotten immunotherapy, and what we see is that these are patients that have gotten immunotherapy. These are patients that have not, and this is separated by if you have a lot of mutations or if you have little mutations. So here you do much better survival if you have a lot of mutations across all cancers. Okay, so the question here is, okay, well, we see this question, does it apply to just lung cancer or melanoma, or does this apply to every cancer? Is this a major rule for oncology treatment? And so actually, if you bear this out and separate them out from tumor to tumor, because we have 2,000 patients, we could answer the question of how specific this marker is. And what you see here is a forest plot, and going this way means that with more mutations, you survive more with immune checkpoint blockade. And what you see is with 1,800 patients is that in almost every single tumor type, it follows this rule. Okay, so if you have more mutations, you survive better, except glioma, and the other one is prostate. Sorry, I didn't put that up here. Those are going to be really hard to figure out. Now, if you actually don't get immunotherapy, you don't see this across all human cancers that we looked at. We sequenced about 9,100 patients up there. So what does this mean? Why, if you have more mutations, do you do better? Well, it's because ultimately, and I'll just go ahead and tell you, there's a lot of work that went into this by a lot of folks in the field, is that what happens is you have a peptide, you have a little protein in our bodies, in the cancer cell, it gets screwed up, and what happens is these alterations are then seen by T cells, and they can attack and kill. And if you have the right neoantigens, the drug can actually awaken your immune system to actually fend off the tumor. We're going to go ahead and skip this, but some of what we've seen in a patient, one of our patients here is this lung cancer patient with an index lesion here. This is a clinical response, and here we found a neoantigen that actually really follows the clinical course very well. So here he got pembrolizumab, he's done really well. The T-cell reactivity to this neoantigen, this HERC gene here, is measured by this axis here, and you can see it goes up and then goes down. So you can kind of use this sort of as a biomarker. And so the trick right now is really just the field is trying to find these neoantigens, because there's a potential for using these as targets for another generation of cancer vaccine therapeutics. What about specific genes? That's been very difficult. Going into this, we had expected that certain genes may perhaps be involved. It's been very difficult to find them. We were interested in perhaps the reverse question of resistance. Why do some people do better? Okay, and what we have basically, one of the signals we found was that if you have mutations in the SERPIN B3 and B4 gene, you tend to do better. So here you have the U.S. cohort. We had analyzed the German cohort, and if you have a mutation in one of these two genes, you actually do better. What is special about these genes? These genes are not the standard genes that people look at, that people test, because the language is different, right? Sometimes we have to look deeply, which is what Moody had taught us. So you look deeply, and it turns out that these genes are actually the closest human homologue to chicken ovalbumin, all right? So why is chicken ovalbumin important? Well, humans don't utilize egg laying anymore. So these are actually conserved proteins over evolution, where these areas are similar to egg ovalbumin, what causes allergy. And the mutations actually happen at the areas in which there's a lot of homology. This area here near the blue is actually what people use to inject and test egg allergy for. And lo and behold, look at those hotspot mutations there. So something about this is triggering autoimmunity. And it turns out that if you have IPI, so the normal CR rate, complete response rate, for IPI is about 1% to 2% in melanoma. If you have these mutations, it's anywhere between 30 to 65% CR. So this is actually quite interesting. And right now what we want to do is actually set up some basket studies looking across all different cancers who have SERPIN B3 to see if they actually respond or not, based on, again, not MSI, but based on the ability of SERPIN to actually provide the anti-tumor rejection. I'm going to sort of close just with a few points here soon with a few slides. We also showed that clonality is important. It's not just that these neoantigens are all the same, but they're not, right? Just like rhabdomyosarcomas in different parts of the body are not all the same. So it turns out that if you are scattered and have a lot of different types of cells, high diversity, you actually do worse. And so how do we think about this in terms of radiation? Well, in terms of radiation, I remember, in residency, we saw a patient, and one of Moody's, things was always to have us physically look at the pathology report, and he would sign that, right? Okay. So one of the times that we did that, we were looking, for some reason, we were treating a metastasis or something. We were looking at an MSI positive colorectal cancer met. Okay, and down there it said, oh, this met was from Hopkins pathology. This thing is 50% immune cells. All right, so 3 days later we kind of didn't think anything about it. Remember, back then immunotherapy was like the career killer, right? Nobody wanted to touch it. And lo and behold, I get this message. He put this message in my mailbox. I would get about one of these a week. Maybe the more you get, the more improvement you have to do, or something like that. But I never figured that out. But I would get a lot of those, right? And then one of them said, "Man, you got to figure out. I don't know if you remember this, but you got to figure out why there's so many lymphocytes in that MSI colorectal cancer, right?" So even back then, those comments were extremely prescient. So here, what I wanted to basically show is that, so how do we actually combine radiation with immunotherapy? I think a lot of folks in this audience, a lot of the faculty members I know are interested in this question. At least I can say for ourselves, based on the early trials that we've run, this has been a very difficult road. There's nothing very obvious about the synergies, but yet once in a while you see a very, very dramatic response. What that's telling us is that there's diversity in the disease, and you just have to work harder to figure out what they are. And that signal may come from a lot of places. I will touch on one paper that my very nice colleague Jed Wolchek had published showing the abscopal effect. This is quite famous patient, and what this was basically what abscopal is that if you use radiation to treat a little area, suddenly the whole body can respond and be cured of disease, and this is basically seen as activating the immune system. This is a very complicated slide, so you don't have to really hone in on this, but this little area was treated with SBRT, and the patient basically was cleared of disease and was doing very well afterwards. And basically what this showed was that this is likely a class 2 dependent mechanism, all right? So a lot of these biomarkers show that. But you also want to ask, are we using the right checkpoints and what tumors associate with this synergy? We don't know, and we have to use the same rigor as with the IRS to actually tease this apart. So, and this is basically my next to last slide here. I personally think that the DDR deficiencies are very important because, as I showed before, MSI, right? MSI, DDR deficiencies, Paul E, Paul D, those patients are the ones that are responding, right? Turns out that those patients are also the patients that we published. If you have somatic ATM mutations, you're an exceptional responder to radiation. So maybe, we ought to look at the low-hanging fruit here and design trials with a precision perspective in mind. So I'm going to end there. I think we'll just skip the summary. These are the acknowledgments for all the folks in my lab, also at our institution. But most importantly, thank you, Moody, for the honor and the privilege of learning with you, and for getting into my head, and for affecting the way we approach problems, because I think that those types of connections that one forms, there are people that say that those types of ways that you touch people are truly what makes you wealthy, and I think you are, in that regard, you are very, very wealthy.
Tim, thank you very much. And I'll just reiterate for the audience how important Tim's observation has been in this notion of immuno-oncology and all these mutations and not. You can now start to figure out who's going to benefit or not. And that is a profound step forward. So Tim, congratulations on that. So now it's time to hear from two of my colleagues who will be far less eloquent than Dr. Chan was, but they'll try to keep up. And it's a pleasure and honor for me to introduce the smarter two-thirds of the best resident class that ever came out of Johns Hopkins, my co-residents, Bob Zimmerman and David Rabin. And while neither actually requires any introduction, they're forcing me to do it, so here we go. Dr. Robert Zimmerman is professor and vice chairman of the Department of Radiation Oncology at the University of Texas Southwestern. Bob was involved in the early development and clinical testing of stereotactic ablative radiation for treating things outside of the brain, so in the other parts of the body, most specifically for lung. And it is not an overstatement to say that Bob's work, I think he single-handedly has transformed the management of lung cancer worldwide, and that evolution is still occurring. And that is going to be as profound as what anything Tim talked about. Dr. David Rabin is professor of radiation oncology at the University of Colorado, and over the last 20 years, David's developed extensive expertise in translation of radiation oncology with a real focus towards the delivery of precision drugs. David did some of the most important work early on with cetuximab, a targeted drug, and radiation in head and neck cancer, which ultimately became FDA approved. And his notion of how we think about these molecular biomarkers that Tim talked about, how we would use that to enhance radiation. So obviously both are highly successful, and it was always my pleasure to train with them. Bob and Dave, please.
Okay, I'm Bob. I'm not Dan. But Moody, it's great to be here. Love to be here with friends and family. It's been a long time to see a lot of you. But Moody, there are times to reflect on accomplishments and honors based on your really prolific career, but right now is not the time. Ted DeWee's first rotation as a resident, I remember it well. I watched him suffer and panic, and it brought me a lot of anxiety because I knew I was next, and I was terrified. Moody, you really took care of some of the most complicated patients in the cancer center, and I don't think many people realize that. and you just sort of spent your time feeling inadequate. But we pressed on because you were encouraging. You had a passion for pediatric cancers, and in particular, Hodgkin's disease. And Larry Kuhn joined our center now, so he's in the office next door to me. And he told me yesterday, just yesterday, that Moody was the first radiation oncology chair of the pediatric oncology group. And his first action as chair was to review all the mantles of all the treatments that were done across the country in these cooperative group trials. And what he found was that 50% of them were inadequate. They were just plain missing the tumor 50% of the time. So now people all across the country, just like me, became terrified of Moody. Because then he moved on to do the same thing with craniospinal radiation, which we've already touched upon. And that was great, though, because this is where you got to get it right, correct? Anyway, when I was on his service, we had a 16-year-old boy with Hodgkin's disease. And every time he laid down, his heart would just move up in his chest. And that's bad because that's where the radiation comes. And so we'd be hitting his heart every time. And so Moody told me that we have got to come up with a way not to do this mantle treatment without burning his heart. And he gave me 2 days. And my first solution, I was really working hard. I had the patient sitting up so that gravity would just pull his heart down and fall out of the way. And I did it by building a trapeze sort of a thing that he would hang on to. And
Are lawyers here?
I spent a lot of time doing this, and I showed it to Moody, and he just gave me that look and shook his head. No, this won't do. He told me that the head could move too much like this, and that the patient's neck would get out of position and it wouldn't be accurate. So in the end, he figured out a way that we could give the patient a bite block to hold on to, and I rigged that up to the same trapeze. So in the end, this poor patient looked like he was hanging from a clothesline by his fingertips and his teeth and getting treated, but it worked. It worked. And we treated the patient, I think, with far less toxicity. Moody decided on another patient that we should treat that patient on her side. This is getting to be strange. You want to treat people in all these different positions. But that's what he wanted to do. So to keep the patient from tipping back and forth when they lay on their side, we fashioned these vertical panels that sort of articulated with each other on both sides of the patient. So the patient was sort of sandwiched in between. And to hold the patient tight in between, we used a brand new product that had just come out called Aquaplast. Basically, you stuck this expanding foam in a big plastic bag, and it would expand and sort of lock the patient in. It was kind of messy, and we hadn't much experience with it. So we set this up. Everything was going fine until the foam started like a volcano erupting between two of these panels and spilling toward the floor. And Moody looked over at me and he pointed to the problem, and that meant I'm supposed to go over there and get this fixed. So just like a good soldier that falls on a grenade, I ran over there and I just pushed my body up against this volcano eruption that's coming toward me. And I didn't like it. It was sort of it was sort of oozing toward me, like going in my pockets. And it was hot. And finally it stopped and hardened. And I stepped away. And to my absolute horror, there was a perfect cast of my private parts. There on this immobilization device. And it was sort of like how they carve in the animals on the Tree of Life at Disney World. Anyway, the simulation techs tried really hard not to laugh because Moody didn't want laughing in the clinic. And I looked to Moody for help, but he just stood there and shook his head. So I ran to the mold room and I found a hacksaw and I just sawed that thing right up, sort of the effigy to myself. So Moody, Wharam, you've taught your trainees to solve problems and to be innovative. I've tried to use these assets throughout my own career, and so thank you very much. I wanted to give you a gift. So last week I flew to Italy and I went to an off back street on the island of Capri, and I pick up your favorite limoncello, because this is a really sour drink, and Moody likes it. And it perfectly balances Moody's disposition. You know, Moody, a sour drink and a really big-hearted, sweet guy. So Moody, I hope you remember me.
Well, I am so glad that I went after Bob Timmerman, because it doesn't matter what else I say now, it will still be sound appropriate after what I just heard. I've kind of got chest pain reliving some of these Bob Timmerman memories now. I was looking over Ted going, oh my God, I forgot about those stories, and they just all came flooding back. So I could actually make this the Bob Timmerman roast if you guys are up for it. I mean, anyway, so let me see if I can get my talk here. And by the way, I want to second what Ted said about your talk, Dr. Chen's talk, just phenomenal. That I like to think that radiation is going to be the fire starter, not the fire, in the next 5 years in terms of immunotherapy, and that maybe we're going to increase those mutational burdens in those cold tumors and do a lot of interesting things. So I'm very appreciative of your talk. Absolutely wonderful. Man, I misread the invitation. I thought it said 50 minutes, and I have 88 slides. But then Ted said you have 5 minutes, and that's with Bob Timmerman, who took up 19 minutes. So I came all the way from Colorado, so I'm going to just let you have it, Moody. Okay. So first of all, a special thanks to Ted for putting this all together. Just a dear friend and colleague, and it's so wonderful when he puts these quotes up that really touched my heart. But, you know, when he told me that he was training for base camp at Everest or somewhere around that, I'm going, oh my goodness gracious. And then he's got this hot yellow sports car, and he's doing this, and then I hear him say, you know, there's not many perks for being a chair at Hopkins. I'm going, wow, can I have some of those perks? So, but Ted, thank you so much for inviting me. You know, Ted, as residents, us three, Ted was the steadying hand, that focused scientist, even during the dark bow tie days when he would walk around with the bow tie. And of course, you know, the future Astro president is enough said. But this is Ted. You know, I'm at University of Colorado. I don't know if people know that Ted went to medical school at University of Colorado. So I'll walk down the hall sometimes in Building 500 and walk by his picture that you can see on the left for the 1928 class. But amazingly enough, he literally looks the same. It is just incredible. Probably none of you know that he was in a biker gang and a lot of other things that I probably shouldn't tell you about, but just an absolutely remarkable person, but that steady, focused guy in residency. So, you know, then there's Bob Timmerman, world-renowned now, distinguished. I remember when he proposed SBRT, and he was lambasted at an RTOG meeting. People ripping his head off. You can't do that. You're going to kill patients. And I'm looking around going, wait a second. Our 60 gray irradiation in the last 30 years has got, what, a 20% control rate? You're kidding me. You think we're going to do worse with this? And look what he's done and transformed it. But you know him as this, you know, very distinguished-looking scientist. You know, the residents out there know who this Bob Timmerman is. But, you know, literally, this is what my perception of him was. And he pretty much corroborated it with the last couple stories you just heard, that this was that vision of him running 100 miles an hour in a sweat up and down the hall with wire contours and making all sorts of contraptions, and patients are holding up like this, and it was just incredible. And then, God forbid, if Moody asked Bob Timmerman a literature question in chart rounds, because this is the look you would get from Bob Timmerman if you asked him anything that had to do with literature or stuff. Just let him build his stuff. And you see what he's done over the last 20 years. It's really remarkable. I was looked at as that confident, hardworking, always calm resident, always punctual. Great at changing slides for the visiting professors. That's an inside joke that I won't expand on. But you know, again, I still feel like I'm in the dark closet. I'm searching for that light over the last 20 years. But it's kind of what Bob was saying and Ted was saying with Moody, that he really ground into you that ability to be as precise as possible, that importance of not being mediocre, that importance of really digging deeper and peeling off the onion layers and really focusing on each patient. And if that meant staying till 4 in the morning back then, that's what we did, because I was scared crapless to show up. I would stand in salute at 7 a.m. outside his door with the stuff to do for the day, because if you were not on time on his service, woe be to you. And it's exactly what he said, what you said about millimeters, just constantly trying to get this perfect. That's what he taught me, to stay up that extra hour, that extra 2 hours. If you were, in other words, if you were comfortable going to bed at night, there was something wrong. That meant you need to get up and go back over it again. And that's what he taught me. And I've never been comfortable in 20 years. And that's what it takes when you're taking care of cancer patients. Ted kind of shocked me when I asked him this question, when were Bob and I last here? And this was this incredible ceremony with this beautiful picture of Moody that was in it. And Ted, correct me if I'm wrong, you said 14 years? 13 years that we were here celebrating this incredible event, an incredible occasion. Just honored. Now you can see, again, I look the same. Ted looks the same, and I'll just leave it at that. So, but you saw this picture before, and I want to say, when you look at this picture, you see this incredibly elegant, statuesque person, this beautiful smile. That's not what I see. Okay? This freaking grin was the grin that I would get when I'd walk to his office starving, because you never got lunch on his service. And I'd open the door to his office, and I'd go, "What did Miss Wharam make for us today?" And he would take his cookies, and he would crumble them, and he goes, "This is what you get, Raven. You get the crumbs." Okay. And so I brought a lunch for him, and it's a hell of a lot healthier than the one he would eat. I've got Chia Squeeze Vitality Mango Coconut. I do have some Little Dipper Ranch and carrots, and some quinoa. Okay, Bob would pronounce that quinoa. But I did bring you some cookies, some Tate's cookies. So. I'm going to get to a couple things. You can talk about Moody till the cows come home. So I try to think about what really reminds me of Moody Wharam. It's these things. It's doing things for people not because of who they are or what they do in return, but because of who you are. And that's one of the things that really always stood out to me about Dr. Wharam. Be somebody who makes everybody feel like somebody. He always made me feel like somebody. He made me feel like I was with him on the team. But the biggest thing that always stood out to me, which is a rare talent, that's to listen. Keep your mouth shut. And I heard that from my father, and I watched it with him for years. He wouldn't say a word in some of these conferences. You could just see him sitting there, listening, and then he would make just these incredibly profound comments at the end of these conferences. And he had this stone face. God forbid if you had him on oral boards. I am sorry if you had him on oral boards. You did not want that. But he had this face where you could see him thinking. Now, I never took that advice, and I wish I had, just kept my mouth shut more during my career. But that's a very rare talent, is to listen and not hear yourself speak. And when I think of Moody, when I was on his service, he had this calming effect. Even though you knew you were stressed and you were going to work your rear end off and you were going to be up late at night, he had this real calming effect about him. And this is kind of, when I see this picture, that's what I think of Moody. It's just that calmness on the water on that boat out to sea. So I'm going to finish with one of my favorite favorite mentors, Master Oogway, who's over 1,000 years old and is the founder of Valley of Peace and creator of Kung Fu and developer of the Dragon Warrior legend. And he said, there's a saying, yesterday is history and tomorrow's a mystery, but today's a gift, and that's why it's called the present. So I feel it's a gift. That's my gift, is to be here for you, Moody. No, I'm just kidding. It is being in this moment right now, in the present, forgetting about the rest of the day, forgetting about your phones and all this other stuff. It's a very special moment for me to be part of this. So I really thank you very much.
Thank you, boys. So you can see why, one, I had a hell of a great time in residency when I was hanging out with them, but on Moody service, oh, God bless, it was stressful as hell. And David, yeah, you haven't also listened to your wife to keep your mouth shut, too. So we should be clear about that. So next, I'd like to ask our panelists to come up, and please take a seat. And as you're doing that, I'll say a couple words about each of you. One of the purpose of this for the audience is for all of you to get a sense of Moody always had this notion that he never changed over 40 years at all. And so I think this is a worthy panel to try to get to the bottom of that and to see if he actually did mellow out from what Dave and Bob and I experienced or not. So the introductions are and over the decades, so we have towards me, Dr. Harmer Brereton, who's representing the residents of the 1970s. And after training at Hopkins, Dr. Brereton joined the faculty of Georgetown University and later started and ran a very successful set of community practices across 3 states. And more recently, Harmer's been intimately involved in the development of the Geisinger Commonwealth School of Medicine in Pennsylvania, where he's a clinical professor. Next to Harmer is Dr. Marilyn Ling, representing the 1980s, and she's an associate professor at the University of Rochester School of Medicine, where she manages a very busy, high-quality breast cancer program. Parenthetically, she's the only person I know who has a certificate from the Cordon Bleu Academy in Paris, by the way. Next to her, representing the 1990s, is Dr. James Wells. Jim is a professor of radiation oncology at Loyola University Medical School, and Jim has had a fascinating career, including being the first person to ever treat patients with helical tomotherapy, by the way, very cool. And more recently, he's had some very interesting work, clinical aspects at the Fermi Lab in Chicago. And finally, representing residents trained in the 2000s is Dr. John Christodoulias. And John is the Vice President of Medical Affairs and Clinical Research for Electa, and is also an adjunct assistant professor at the University of Pennsylvania. And John, too's had a fascinating career. Really a bladder cancer expert, doing some very interesting ways, novel ways to think about incorporating radiation post-surgery and using those kinds of insights to develop things in industry that will really leverage the clinical acumen that he has in driving device production. So that's who we are. So let's start with Dr. Brereton. And so I'm going to ask a question, and then I'm asking her to reflect and then provide other things that they might want to say. So, Harmer, okay, so remember, 1970. So it's the 1970s. We're coming out of the Vietnam War. Moody's an ex-naval officer. So, Harmer, is it true that morning conferences with him in those days were basically like an apocalypse now sort of thing? I mean, did Moody actually say that he loved the smell of resident stress sweat in the morning? Is that true?
That actually defines him perfectly. I'm here really for many good reasons. To thank Moody in so many ways. But your description of him actually fits exactly what I found on my first day. In fact, I felt like I was one of his early victims, no residents. But the first reason I need to thank you, Moody, is that when I was 35 years old, and a medical and oncologist and a hematologist, I told my wife, I want to go back into training. And she said, no, you need a job. You have 2 children. And I said, but I've just got to do this. And there were some very good reasons. And I remember coming over and talking to Moody and Stan. And they made an accommodation for me so that I could support my wife and children. for the time that I was doing my training here. And I could not have done it without that, and I am ever, ever grateful. So are all my patients. But I remember the panic and the terror of morning report. And the rigor that was required, however, has stayed with me. You had to have your patients totally prepared. Every day there was a presentation by somebody on the resident staff that were so good, you kept them. I had kept them for years, using those as references for my training. But the description that we have of you, of the meticulous and the gracious way in which you practiced, has never left me. And I think about that every time I have a morning report, every time we make chart rounds. Moody, you would feel very comfortable because they are your morning reports and your chart rounds. I'd like to reflect on just one case that we had together that you might have forgotten, but I haven't. And that was a young woman who had adenocarcinoma of the lung, and she had a malignant pleural effusion. And we were so worried about how to take care of this woman because there was no effective chemotherapy for her, and I was worried about the tumor outside the radiation field. And we concocted something that I don't think had been done before, but probably has been since, and that was put a chest tube in and use colloidal P32 in her pleural space. And we worked on that and did that, and I took care of her in the hospital, which was another one of the lessons that I learned here. Take care of your patients. Look at your own pathology. Look at your own x-rays. Don't be afraid to make rounds, and go to the operating room with your patients. All of those were wonderful lessons that allowed me to go in an entirely different direction. I listened to how Tim took his immunogenetics and went it his way. Mine was to develop a care of patients in a community, and we developed the concept of the primary oncologist, which I believe is the radiation oncologist. And we said to our community, if you think in your primary care office that you have a patient with cancer, call us, we'll see them now. So we saw all the patients before anybody else did. It was our way of dealing with the problem of urorad, for example, because anybody with an elevated PSA we saw first. And those skills and that confidence really came from that. So I'd like to close by just reminding myself and all of us that we can learn from books, we can learn from lectures, we can learn from examinations, but medicine is really an apprenticeship. Our mentors show us how to behave and how to do it. It's a huge privilege for me, Ted, to come back to this magnificent institution. Thank you for the invitation. And to also acknowledge Moody's mentoring and his friendship. And to say, again, thank you, congratulations, well done.
Harmer, thank you. And just for the residents are presently, I'm telling you, it was terrifying. It's terrifying in those days. So we're going to move on to Dr. Marilyn Lee. Marilyn, representing the 1980s here. So the 1980s was all about, right, big hair and shoulder pads for women. But is it true that Moody actually loved that Miami Vice look with the gold chain and the tight polyester pants? Is that right? You told me that? Is that right?
That would be absolutely right.
Yeah.
But not on himself. He always had that steady facial expression. And I think he liked David Bowie in the 1980s. And if the resident was not meeting his expectations, the song Under Pressure would be played. Meanwhile, if they were doing okay, he'd say, let's dance.
Thank you, Marilyn.
Like all the others have said, thank you, Ted, for inviting me here. I don't know why I'm here actually, but I do know why I came. It was all because of Dr. Moody Wharam. And because of Dr. Moody Wharam, I'm scrambling to write things down meticulously to make sure I hit a few high points that I made. Because I actually went to residency in 1989 and finished in 1992, 25 years ago. So I was not the 1980s per se. Although, if you knew me, I was here in the 1980s because they welcomed me as a college student. And I would come down to the morning reports, which back in the day when I reflected upon them, everybody was nervous to make sure because we review which case would they present and grill us on, Dr. Order and the rest. And they used the Socratic method, which I don't know if it's being used these days, where we had to figure it all out. But be that as it may, when Sir William Osler was preparing to go to Oxford in 1905, he gave a famous farewell speech to his colleagues at Johns Hopkins and said, "I desire no other epitaph than the statement that I taught medical students in the wards. As I regard this as by far the most useful and important work I've been called upon to do. There is no doubt that Dr. Wharam, who regards Sir William as one of the greatest physician philosophers in history, agrees completely with this statement. Dr. Wharam has a wonderful and remarkable career as a physician, scientist, and medical administrator, but I am certain he regards his role as a teacher to be a high point of his long and distinguished career. Dr. Wharam is such a teacher to me, and an exquisite one at that." The program for today mentions my era. Again, I graduated in 1992. I was the last of the 3-year residency programs. I don't know if people knew that. Now it's 4 years or more. My active times in Johns Hopkins Radiation Oncology began during my college years in the early 1980s through bench research with Jerry Klein in 1983-84. I attended those morning resident conferences and the Wednesday afternoon machine chart rounds, where we go from machine to machine, the whole department. And we'd be asked also then what to do, and was it right? Dr. Wharam was always ready, willing, and able to be the best of the best as an outstanding teacher, a practicing doctor who has excellent knowledge and judgment, and one who practices the art of compassion, all in fine balance. He has been a master of the entire spectrum. And this is very rare and requires great dedication, hard work, discipline, good organization, and also the best sense of humor. He conveyed this all to me beginning as a humble college student and beyond. Dr. Wharam arrived at Johns Hopkins in 1975, invited by Dr. Stanley Order. Dr. Order was brilliant in so many ways, and one example was in his selection of Dr. Moody Wharam to join the team. Dr. Order was the front man, so to speak, and Dr. Wharam was the steady, unwavering beacon for just about everything else. He was there at the very beginning with a small and remarkable team to establish the presence of radiation oncology at Johns Hopkins, leading it out of the dark ages with state-of-the-art knowledge and creating state-of-the-art facilities, of which there have now been quite a few versions. I remember the team Dr. Wharam surrounded himself with: Yvonne Green, Jennifer Buckholz, and his colleagues, Dr. Order, Dr. D.J. Lee, Jose Pino y Torres, Dr. Zinreich, Carol and Joe Deagle, Jerry Klein. It was the best of times with so much hard work, and together the energy and achievements continued to build upon itself. When I finally actually truly began the residency program, I was no longer an observer, but an active participant in those rigorous morning teaching conferences with the residents. Dr. Order, as I mentioned, used that Socratic method, and the residents would bond even more, trying to guess which cases from the day before we would be thrilled about. In front of all the other attendings, personnel, peers, our small room with modest desks side by side forced us to be close, and all the while with these wooden plaques surrounding us, mounted on the walls with sage quotes. Dr. Order and Dr. Wharam collected phrases of the essence of radiation oncology from some of the professors and luminaries of the time, and had these placed on plaques, probably hoping something would seep into our thick skulls and fuzzy minds. I would love to see these plaques and quotes again. We were talking about them earlier today. One of Dr. Order's quotes went something like this: "A resident not questioned is like a ship without a compass." This was in essence furthering us to read and go into the profound nature of subject, evidence-based medicine at its finest. A lot happened during my 3-year residency, including the passing of the torch from Dr. Order to Dr. Wharam, and there you have it. Dr. Wharam was the steady torch, again the beacon, through which all of us knew the division and department it would become would weather through and continue to shine. I began with a quote, and if I may, I will conclude with a few more from these plaques. See, something did seep in. Dr. Henry Kaplan of Stanford, who had helped to develop the linear accelerator, said that the essential element of being a radiation oncologist is the judgment that goes with being a good physician. Dr. Phil Rubin, and I am now at the University of Rochester, where Phil was, founder of the Red Journal, said, "The first decision in cancer treatment must be multidisciplinary and right. There is seldom a second chance for survival." Dr. Simon Kramer, the founder of RTOG, stated that the challenge for radiation oncologists is to be a skilled oncologist who understands and interprets the disease process in all body systems. He must be a consultant's consultant. Dr. Wharam practiced and embodies all of these facets and taught these, always leading by example. He conveys the judgment of a great physician, always working in multidisciplinary fashion for what is right. He is so very skilled with keen understanding and interpretation. He is a consultant's consultant with technical excellence replete with compassion. Thank you, Dr. Wharam, for being the extraordinary teacher and mentor that you are. As Dave said, you are truly gifted and a true gift to all of us. Thanks.
Thank you, Marilyn. So next we have Dr. Welsh, who trained in the 1990s. By this time, Moody was already entering, I guess, your third decade at Johns Hopkins. Earlier, Jim, you told me that Moody was becoming sort of hard to understand at times and seemed somewhat aggressive, but is that really true, or was that just being confused with his gangster rap phase?
Well, thanks, Ted. As I think about this, that was no phase. Dr. Wharam is one tough man. There are a lot of things about Dr. Wharam that are truly admirable character traits. I started to think about them and jot them down, but the list would be much larger than the Perez and Brady textbook, and I got to be back to work on Monday mornings. I cut it down to something a little more concise. What are some of the great attributes of Dr. Moody Wharam? Well, number one, I remember noticing that he was an exceptionally creative thinker. Dr. Wharam was thinking outside the box before the box was even invented. That might not sound so good. What I mean by that is Dr. Wharam was a great three-dimensional thinker before 3D conformal radiotherapy was even conceived. And he taught us to think critically and think synthetically in that similar fashion. An example I recall was a very simple one where I spent some time designing blocks for a young lady with meningioma. And Dr. Wharam asked me, what about that fourth field you have? What about that vertex field? Anything you want to think about that before you show me this in depth? Oh, it must be exiting through the spinal cord. No, it's not. Take a look. Well, what's Dr. Wharam getting at? Oh, I was dumb and dense. But he said, don't you remember in that H&P you wrote that this young lady has a family history of thyroid disorders? Several people in her family have thyroid disease. Do you think that she'll be around in 15 or 20 years? Yeah, I think if we do this treatment, she'll be around. What do you think you're going to do to her thyroid with that field? I didn't think about it at all. And the fields may not be unacceptable, but what is unacceptable is to have not thought about that. I thought that was a very interesting and important lesson. And another example I remember was Dr. Wharam's ability to come up with creative ideas that I probably never would have come across in 1,000 years. Maybe guys like Bob Timmerman would have been able to figure this out. But there was a case where we had a person that had spinal metastases and had already been treated. Surgeons weren't going to take him to the operating room. What are we going to do? Well, Dr. Wharam said, well, you need to think about this. Would this work? Put a block in the center, block in the spinal cord, and rotate that block around the patient. And it actually made sense. It was technically very hard to do back in the 90s, but now everybody in the world is familiar with volumetric arc therapy and tomotherapy. Dr. Wharam was thinking way ahead of his time with ideas that only a decade or two later came into fashion. Dr. Wharam wasn't a physicist, but he had a keen appreciation of the important role that physics plays in the clinic and the careful interplay between medical physics and radiation oncology. I remember having the honor of being here on faculty for a while after I completed my residency, and having the honor of starting the prostate brachytherapy program. But Dr. Wharam and Dr. Luis said, do we just want your program to be another Me Too brachytherapy program, or is it going to be something special, something that is worthy of being here at Johns Hopkins? So thanks to Ted's research and the radiobiology team's work, we thought about putting the seeds in first so that the external beam radiation therapy that would come a few weeks later might be benefited by the tumor cells being sensitized to the low-dose radiation from the seeds. It's an interesting concept. But Dr. Wharam, being one step ahead, said, can you do even better than that? And I started to think about the fact that we were putting the seeds in first. And Dr. Wharam, thanks to his versatility, was covering the GYN service. And he showed me a port film that had a fiducial marker in the cervix. And I could see the fiducial marker on that port film. I thought, well, if I'm putting in iodine 125 seeds, why don't I put a marker in? Which marker would be best? So he and the physics team encouraged me to do a little study, and silver markers, gold markers, as long as I could put it in there with a MIC applicator during the brachytherapy process, and as long as I could see it on the port films, maybe I could guide the subsequent radiation therapy. I actually tried to patent that while I was here. And if I were successful, and if I got a quarter for every time somebody put a gold fiducial marker in, we'd be having this on my yacht and mansion. I wrote a cool paper on the subject. But this was another example of Dr. Wharam's ingenuity, his creativity, his ability to think years ahead of his time and inspire us to think similarly. There are so many other things I was thinking about when I was invited by Ted to join you for this tribute. And, you know, as you asked me, Ted, was Dr. Wharam a tough man? Yes, he was a tough man. I remember one example where there were a good 30 inches of snow on a Monday morning. My car went about 30 inches before I had to give up, and I called the clinic expecting there to be no answer. And of course, Dr. Wharam. That was the last thing in the world I wanted to hear. Dr. Wharam, it's Jim. Yeah, Jim, where are you? I'm behind schedule. Yeah, I've noticed. When are you going to get here? Oh, I'm working on it. By the way, how did you get there, Dr. Wharam? Just, I'm a tough man, Jim. To this day, I still don't understand how he got it. But Dr. Wharam is a tough man. He's a demanding man. Some people have said that he's a funny man. Now, I wasn't so sure that I got that sense of humor way back then, as I was the brunt of many a cruel joke and pranks, but I probably deserved each and every one of them. One that I do recall in particular was a very challenging case where I had designed very careful fields and blocks for a pediatric case. And I was so proud of this, I couldn't wait to present this to the great Dr. Wharam. He's going to think I'm hot stuff, finally. But he was there reviewing the films already with my co-resident, Dr. Tarantori. And I remember Dr. Wharam saying, oh, Jim, I was wondering when you were going to finally show up. You know, pediatric cases can't wait. You know that. You know better than that. So while you were on vacation or off gallivanting and doing God knows what, Dr. Torrey and I picked up the slack and finished your job. And I said, but Dr. Wharam, I designed those blocks. Jim, you're gonna have to learn to speak up and stop your mumbling. Speak like a man. Do you have something to say? And I looked over to Taryn and I was, are you gonna say something? She just kept her mouth quiet. And, at the end of it, I asked Taryn, why didn't you say something? She said, well, that was the funniest thing I ever saw in my life. So, you were squirming in your chair, wiggling and turning red. I saw you cursing and mumbling under your breath. It was just hilarious. Dr. Wharam and I just thought that was the funniest thing I'd ever seen in our lives. You were both in on it? Oh yeah, it was hilarious. At the time, I guess I didn't appreciate the sense of humor or get it. Today, that was pretty funny. So Dr. Wharam has been demanding. He's been creative. He's a tough man, and yes, maybe even a funny man. But what is the truly greatest thing about Dr. Wharam? You know, one thing that stands out the most, harken back to the very first day of my residency training, when Dr. Wharam sat down with me and Taryn Torrey and Shupe Fang and said, when you've finished, you may know all about the EGFR, RAS-RAF, NEC-MAP kinase pathway, and you may be able to tell us all about the molecular biology of FOS and June, but if you're not a great doctor, if you're not a good doctor by the completion of your residency program, we have failed. I remember that. And I wasn't sure exactly what that meant at the time, but every day of my training, I thought about those words. And now I realize that having a great deal of medical knowledge and a vast fund of scientific knowledge is necessary, but not sufficient to be a good doctor. There's a lot more to it. One has to be, has to have insight, and has to have judgment, and has to know whether the patient, the person in front of you, is going to be able to come in for 35 days. Is that person going to be able to make it? If not, maybe radiotherapy is not the best choice. That's the kind of judgment that is important in radiation oncology. Sensitivity. That's something that is important to sensitivity towards the students and sensitivity towards the patients. Something that's critically important that a lot of those who are technically skilled and intelligent may not have. Dr. Wharam has these attributes in spades. And Dr. Wharam is a creative man. He's a funny man. He's a tough man. But he's a great man. And I have to say that during the era of Dr. Wharam's leadership, it was almost impossible to graduate from this program without becoming a good doctor. You never failed us. And thanks to your request, every day we try not to fail you, and we try not to fail our patients. Thanks to you. Thank you.
All right, thank you, Jim. So finally, we have Dr. Krista Dulius, who trained in the 2000s. And yes, Moody, you were starting towards your fourth decade at Hopkins by then. And I know the concept of whatever work-life balance, whatever that is, really took hold during this time. And you once told me, John, that Moody felt, or I guess you thought he was becoming more contemplative at that point in those days, and sort of bought into this cult-like philosophy of work-life balance. But do you think that was accurate, or were you just catching him after one of those, hot Bikram yoga sessions he was doing?
I think this was a different era, Ted. The fourth decade was clearly his mentorship years, just to set the stage what it was like in the aughts. By this time, the IRS studies had sort of matured, and we had all seen sort of the magnificent work that was done on these extremely rare tumors. And just to be very clear for those of you who are not in radiation oncology, what Dr. Wharam and his colleagues did was put together an infrastructure, a collaborative infrastructure that allowed us to learn more about
these tumors that are extraordinarily rare, rhabdomyosarcoma, for example, 350 cases a year or something in the United States. We've learned more about rhabdomyosarcoma than bladder cancer, which is 14,000 cases a year, and it's because of the work that he did. And so by the time the aughts came around,
He was a legend. Okay, you came to this program, you knew who Dr. Wharam was, and you knew what the IRS studies were and the importance. And when you were around him, in this decade, he had it all, right? He had already had the career, the killer career, the clearly highly impacted career, this gorgeous family, and in this era, it was a lot about mentoring the younger folks. And one of the things that he wanted to demonstrate to us is work-life balance, Ted, as you brought up. And I think my year was the very first year he decided to have work-life balance. And how do I know this? My first rotation at Hopkins was also on the pediatric service. And just to break the ice a little bit, he invited me over and some others to his beach house. And I'm pretty sure it was the first time that anybody had actually been to the beach house. And what he wanted to do was sort of demonstrate, we're going to work hard, but we can have some fun and relax. And he was going to grill. And you just have to imagine, again, here's this legend now in shorts.
I'd rather not, really.
And he was going to grill. And we were sitting by the grill, and he was opening up the grill. Like looking at it and looking around. This is the man who had total command of absolutely everything, worshipped in the hospital, and he didn't know how to grill. It was very clear that it was the first time he had approached this appliance. And she was like, just turn that knob, honey, and just go like, there you go. And he grabbed the tongs, he grabbed them from the other end, I'm pretty sure. And I was like, okay, there's a chink in the armor, a legend. But I think the work-life balance thing probably took off from there, and I'm sure you're a grill master now. But speaking of his philosophy, I wanted to mention one other thing that was very important to those of us who trained with him in the aughts. And it actually comes from an anecdote. Anecdote,
that's different, John.
Yes.
That's a Swarthmore education for you.
Anecdote. It comes from an anecdote from the first time he retired, because he actually retired multiple times when I was a resident. Retired, came back. And in his very first retirement speech, he actually said something which I carry to this day, which I still remember, and pretty much the most important thing that I heard Dr. Wharam say. When he retired, again, this absolute legend in the field who gets credit for a lot of the pediatric developments that occurred in the IRS studies and other POG studies, said that one of the most satisfying things in retrospect about his career was his relationship with the young people, with his trainees. And I remember that like sort of taking this huge weight off my shoulders, feeling like, I can have a satisfying career too. I don't have to like pull off these legendary studies or have this huge impact on the field. You can have a great and satisfying career through these personal relationships, because if that guy finds it to be his most satisfying memory of his career, then that's something that we can all attain. So I still remember that. It's this like beacon that I keep in front of me as I make my own decisions in life, and I really thank you for that and all the other things that you taught us.
Thank you, guys. Well, thank you all. Next, we're quite fortunate to have with us Mr. Patrick Brennan, who is one of Dr. Wharam's former patients. Mr. Brennan is the director of the gift planning office at the University of Notre Dame in Indiana. He's an attorney by training, having graduated from that same institution, and I think 1999 found his way to Johns Hopkins and to Dr. Wharam for one of his own illnesses, and I'm quite sure that was very profound, and he's been kind enough to come to us today and share his thoughts on Moody. So, Mr. Brennan, thank you for coming.
Thank you. Privilege to be here.
Again, thank you. In my lifetime, I have been blessed to have many privileges, but none have ever been more sacred than to be here today and to honor the work of Dr. Moody Wharam, my physician and my dear friend of many years, who exactly 20 years ago today was fighting to save my life. But that was only the beginning, because by his example, Dr. Wharam also showed me how to live my life after cancer. I grew up in Baltimore, and after 7 years of work and 2 years of applying for admission, became the first student ever to begin in a community college and to be admitted to law school at the University of Notre Dame. It was my dearest dream to be at Notre Dame, and one day, almost entirely without notice, my dream collapsed when I lost my balance on the campus. Almost entirely without notice. It was a malignant brain tumor, and because that tumor typically presents in the lives of young children, I became a patient of Dr. Wharam's. Dr. Wharam once said, "I got you because you are a big kid." And I have to admit that even at the age of 27, I was always so proud when Dr. Wharam pointed at me and said, "You are made of tough stuff." I was always so proud. So we got started, and I immediately appreciated that the work of Dr. Wharam's lifetime was grounded in science and in physics and in engineering. But it didn't take me long to figure out that Dr. Wharam's work was grounded in so much more. Some of the most sacred aspects of life itself, and even all of eternity. So again, we got started, and I learned so many lessons from Dr. Wharam. The first lesson today is the most important one. There is no higher way to return the investment that God made in your life than to have spent an entire career making a similar investment in the lives of countless others, so that those lives may continue. And it is no overstatement at all to say that in important aspects, Dr. Wharam's lifetime parallels the lives of Jesus and the Blessed Mother themselves, because his relationship to his family and to his patients has been a relationship of complete self-giving. The second lesson I learned from Dr. Wharam is each one of us can be the face of God in the life of a person who needs us. Of the countless things that Dr. Wharam has done through the years that have impressed me, nothing ever impressed me more than the care he took of my parents during my time in the radiation oncology clinic, and the concern he still has for my parents after the passing of so many years. Nothing ever impressed me more. And it was in seeing Dr. Wharam reach out to my parents, and even the look on Dr. Wharam's face when he reached out to my parents, that convinced me to a certainty that every human person is created in the image and in the likeness of God. And because of that, each of us can be the face of God in the life of a person who needs us today. The third lesson I learned is that just because you've had a serious fight with cancer, and just because you've had radiation therapy doesn't mean that now you are damaged goods. It means you have an invitation to be something better than what you were before. And as beneficiaries of Dr. Wharam's giftedness, and more importantly, his grace, a brain cancer survivor of Dr. Wharam's could emerge as something truly miraculous, something entirely different from what they were before, but something far more beautiful. For me, and for so many of Dr. Wharam's patients, one of the most important affirmations we have ever known of the value of our individual lives, the value of our lives to our families and to our communities, is the extraordinary investment Dr. Wharam was so pleased to make in our safety, in our well-being, and also in our dearest hopes and dreams. And I can remember like it was yesterday, my first meeting with Dr. Wharam. And I remember he said, we have two goals. And the first goal is we're going to get to a complete cure, if that's God's will, and if it is at all attainable. But we have a second goal, and the second goal is we want to return you to the University of Notre Dame to finish the work you have begun. And for a good reason, the work never ended. Because after I was graduated from the Notre Dame Law School with honors, the University of Notre Dame hired me, and I've been working there for the past 18 years. 2 years after my graduation, Dr. Wharam, his wife Sheila, and I celebrated on the Notre Dame campus over the Nebraska football weekend. I didn't like the result of the game, but we had a wonderful weekend. And after 18 years of work on the Notre Dame campus, I can say that a little part of the life of Dr. Wharam and a little part of the career of Dr. Wharam lives on the Notre Dame campus. And it can be seen in countless places on our campus. So at the end of the day, on behalf of his patients, I want to say that we are deeply and profoundly moved and affected that Dr. Wharam cared so much about our lives and the lives of our families that he has dedicated such an extraordinary amount of his time on this earth to our well-being. As the patients of Dr. Wharam, today we do not honor a career because it is moving toward retirement. Instead, we honor a career that we know is entirely incapable of ever being retired because it has a life now all of its own. So on behalf of the patients, and especially the generations of children through the years, Dr. Wharam, I just want to say, we love you, we admire you, and we appreciate you more than you will ever know.
Thank you, Mr. Brennan. Very powerful words. I know you do speak for the thousands of patients that Moody has treated. So thank you for sharing that with us. Thank you so much. So it's now my great honor and pleasure to invite the man of the hour, for whom we all have indeed great love and respect, Moody Wharam, to say a few words. So we're going to have Moody do his remarks out when we're having a little bit of refreshments. And Dr. Wharam's going to get a quick little break, and then we're going to do that in just a moment. So I want to thank all of you from the bottom of my heart for coming to share this really important time in the life of someone who has meant, as you can tell, so much to so many. And indeed, Mr. Brennan, I think the way you articulated it was beautiful, which is when one gives so much, indeed, through his trainees, through the patients, their life indeed does continue. Their influence absolutely does continue. And I know I can speak for my two very dear close friends where I know that's true. So thank you, everybody, for coming. And please, we have spent a lot of money on this great food. So I hope you'll come out and join that, and then you'll hear Moody's remarks and one or two other things to say. So thank you again.
Well, I want to begin, first of all, by telling you my great fear today was that there'd be a lot of exaggeration. And there wasn't any, so. Very pleased about that. Yeah. So, as with many academic talks nowadays, I have to begin with a disclosure, and we can take my collar off, love, okay?
Okay.
I have to begin with a disclosure, namely that I actually had to retire from the clinical service 4 times before they would pull this off for me. So any of you faculty out there have delusions about this happening to you, that's what you're in for. So, there are, we measure things like how old we are and how long we've been living in a certain place with a simple number, so many years. But there are surrogate measures of assessing the passage of time. And I was reminded of one of those today. And I make these remarks to everybody, obviously, but also to the current residents. Would the current residents raise their hand? Okay, Ted, make a note of who's not here, please. That's good.
Some things never change.
Well done. Well played, Moody, well played.
And these surrogate measures can lend an element of reality and shine some light on what those years were like. And so in particular, for the residents now, I want you to know that I had residents that I helped train who are here tonight, who are grandparents. Think of that. Huh?
Yikes.
And more than one. Congratulations, Harmer. Yeah. Well, I too want to acknowledge this opportunity to thank the organizers of this event, Ted, so much, Adrian Allen, and Marie Jo Corey on the business side of things to help put this together, and my daughter Ann, who's helped out with some of it also. Thank you very much. And I want to go back a good many years when all this began. The first person I would acknowledge is Dr. Al Owens, for whom this hall is named. Al was the first director of the Comprehensive Cancer Center. He recruited Stan Order, as you've heard, from Marilyn Ling. And Stan recruited me and DJ Lee. Is DJ here by any chance? No. DJ did our head and neck service for many, many years. Stan recruited a gentleman we borrowed from the Applied Physics Laboratory, Dave Grant. And I am so thrilled, Dave, that you are here today, our first medical physicist from the Applied Physics Lab. Wonderful man. And so that group, along with Joe Deagle, who was already here, and his wife Carol, a radiologic technologist, were the sort of the foundation for the beginning of radiation oncology in the era of the Comprehensive Cancer Center. We had, I think, a lot of the clinical chiefs rooting for us. we had lofty goals. We wanted to be a department that was worthy of the Hopkins name, both in terms of cutting-edge clinical work and also laboratory science, laboratory research. And the people who were backing us up, there are two in particular. One of them might be here that I haven't seen. Is Rich Grassi here? No. Rich was the chief financial officer and was a big help to me. And I should have mentioned that Simon Arnstein came with Stand Order, and that group was a foundation for RAD-ONC. But there was one person who always had our back, so to speak, and surprisingly a non-clinician. But he had the insight that, in fact, RAD-ONC could be a department worthy of the Hopkins name, and that was Don Coffey, who's here in the front row. I think Don would tell you we didn't exactly achieve all of our goals right away, but I think it was important to be a foundation. And achieving the goals of greatness that we wanted, in fact, had to wait until Ted DeWeese came along. In my time here, I've interacted with many, many different departments because kids get cancer in every part of the body. So I interacted with endocrinology and ophthalmology, neurology, orthopedics, peds anesthesia. But there are three departments I interacted with primarily, and the first being medical oncology. And two of my best buddies, I think, are at the national cancer meetings right now and not here, Skip Grossman and Dave Ettinger. The other department, of course, was pediatric oncology. And I served under 5 directors of peds oncology. The third one is here, Kurt Sivan. Great to see you, Kurt. Kurt's now the director of a major laboratory at University of Maryland. And of course, Don Small, the current director of peds onc. Honored to have you here, Don. And then, in particular, the department where I knew the most faculty was neurosurgery. And I don't know that the chief is here, Henry Brim, but I work closely with him, and I guess the best known person, Ben Carson. I worked with Ben basically his entire career here. Also a wonderful man named Daniele Regamonti, who could not be here today. And in some ways, those 3 departments were the models for the level of excellence that we wanted and Ted wanted to achieve, which Ted eventually did. I want to acknowledge a few other people and say to the non-medical audience that RAD-ONC is one of the few specialties where we make our own medicine. You don't think of that. It's a medicine you can't see, feel, touch, smell, and so we need real experts, namely PhDs in medical physics, to tell us what the heck we're about to do. And so I want to acknowledge John DeSellin, if John's here or not. I already mentioned Dave Grant. But I hope, is Lee Myers here? There he is in the back of the room. Lee was always available when I needed help, which was all the time. The other specialty within RAD-ONC that the patient never sees is dosimetry, the people who tell us exactly, who take our direction to tell us really the best, most efficient, safest, most effective way to treat a patient. And I want to acknowledge Diane Latronico, who retired recently, Juan Jackson, Mario DeHaan, Leslie Bell. These were sort of a nidus of people. And I refer to them in part, realizing I'm leaving other people out, because they are part of the Hopkins lifers. You know, they came a long time ago and still here, most of them. I've been particularly blessed with the nurses I've worked with. And I don't know if Mary Ellen Blinky is here or not. She goes back to the 70s, I believe. But Jennifer Buckholtz, Karen Held, and let's see, my nurses are probably working in the clinic right now. Is Danielle here? Danielle Crump is here, wonderful lady. And Lisa Katulis, is she here? There she is. Hi, Lisa. Thank you both for coming. Been such a pleasure working with you. And the people who actually treat the patients are the radiation therapists. And again, I'm going to mention mainly lifers. And let me just ask, Annette's here, right? Annette? No, Annette? Well, Melinda, you can tell me, how many radiation therapists are there?
In Hopkins?
At Hopkins, yeah.
We have 36 now.
36. Well, I can't mention 36. I don't know them all. But again, I want to mention the lifers. Melinda, whom I just spoke to. Marcia, who's here. Mary Ellen, Emmy. Lisa. Lisa Nobile, who's here somewhere, I think. And Annette, our chief therapist. I don't know if Annette's here or not. Wonderful people. I have to mention my secretarial assistant of several decades, Yvonne Green, who regrettably could not be with us. And just generically, I need to mention all the residents that you've heard about, and you've heard from some today. It's been part of the joy of my life. There have been many, many medical students I've had the privilege of working with. There's one here in particular tonight, who I see up there on the right, Mohan Suntha, who went from being a medical student to a rad-onc resident, recently completed his presidency at the St. Joseph Hospital, and now has a major position at the University of Maryland. So that's the kind of students we get through here. I also obviously want to thank many, many patients and parents for the trust they put in me and our clinic. I can think of no better way to conclude than to thank my family and to ask my 5 grandchildren to stand up and wave. Wave. There are 3 other grandchildren in Boston, and 1 on the way, for a total of 9. So anyway, let's conclude my remarks. It's a joy to have you all here. I'm honored by your presence. Thank you so much. Give the microphone. Thank you.
Thank you, Moody, very much.
Yeah, sure.
So I'll close as I started today. This is an absolutely wonderful day. It's for an absolutely wonderful man whose legacy is unrivaled in amongst all of us here in this hallowed abode of Johns Hopkins, who means so much to all of us. And Moody, it's time to eat.
I'm all for it.
Thank you again
I'm
for
for it.
coming. And let me just say parenthetically, won't do this now. The 2 gifts we have for Moody, one is a replica of the key, the original key to the Johns Hopkins Hospital
nice.
front door.
Very nice.
And the second is a Waterford crystal platter, if you will, that has some inscription on it about today's important day.
No, thank you so much, Ted. Thank you.
Thank you again for coming.
Dear Moody, I just wanted to tell you that how much I admire you. You are the first one that I ever knew at Hopkins. You hired me, and since then, there hasn't been a moment that I can think of that I stop admiring you. The way you handle everything, the way you manage the department and guided us and mentor us, everything. So I'm so amazed how you even handle this illness that you are struggling with. And I'm so honored that I can say that I know you, and thank you. I just want to thank you for being there for all of us. So we love you.
Hi, Dr. Wharam. This is Lauren Murphy, your favorite patient. So I just wanted to say, the very first time I came to radiation oncology, my mom and I came, and we saw your nurse who prepped us, and my mom goes, "So we're seeing Dr. Moody Wharam. Does he live up to his name?" And the nurse goes, "I plead the fifth." Well, I gotta say, Dr. Wharam, I don't think you're moody at all. I've heard lots of stories, but it sounds like more you're just kind of funny with these guys, and you just make sure that they're getting it right. So you were always so kind and so sweet to me, and have stuck with me my entire life. And I appreciate that you kept in touch too, all of this time. There's nobody more deserving of such an incredible retirement party, and I am so glad that I got to be here to witness it. And say, happy retirement to you too. As a representative of all of your patients, we love you and we care about you, and we thank you for everything that you do. Have a happy retirement.
Hi, Dr. Wong. You may not know me, but I worked in medical oncology and medical records in the radiation department when you were covering Dr. Sigwanetti. And Bisha Brown was one of your patients, and she talked so highly of you. And so when I got a chance to see you walk past, I was very honored to be working in radiation oncology. And now I'm a part of Dr. Song's team as a administrative coordinator. So I'm very grateful to be here and celebrating your life as a doctor.
Dr. Wharam, I can't believe how much time has passed. I was one of the first classes in 1977, and you taught us classes with the residents, and it meant so much, and we had such a good time. And of course you taught us the perfection in millimeter Moody. It's been a great experience.
Hi, Dr. Warren. Just want to let you know that we will miss you from not being around walking the halls all the time. Just a reminder, I came in 1986. It was a long time ago, and I know you don't remember, but I do love you, miss you, and I hate to see you not being around. Thank you. Dr. Warren, this group has something to say to you. We know you don't know this. We've kept it a secret, but this is what it is. We love you, Dr. Warren!
Hello, my name's Justin Nicky. I was a patient of Dr. Wharam in 2001. I was 9 years old, and I was diagnosed with medulloblastoma. And I believe it's through Dr. Wharam's treatment when I was in radiation that I am here alive today. I'm 25 years old, and I've been having a successful life. Thank you, Dr. Wharam.
Hi, Dr. Wharam. I just want to say thank you for everything. I owe more to you than I think I could possibly tell you, and I think I realize every month something else that I've learned from you and that I try and bring to bear. A lot of times I think of you as the voice in my head that guides me to teach in a certain way or interact with patients in a certain way or to try and lead in a certain way, so thank you. And it wasn't something I think anybody on the panel wanted to share, but one of my favorite memories is a little present you gave to me when I was leaving residency. It's a little plastic bag that you handed to me with that smile that people kept referring to in the talk, and inside the bag was Ross Abrams' nameplate from his door, and I still have that with me, so love you and thank you for everything.
Hey, Dr. Wharam, it's Lisa and Danielle. Like you didn't know that, right? We just want to tell you we love you.
Adore you, miss you.
And wish you were with us every day. I will never forget that sweet summer on head and neck. Take care. Bye.
Hey there, Moody. I just wanted to say thank you so much for all of the wonderful times, all of the good years at Hopkins. I think especially right around the turn of the millennia as we're coming into the Weinberg building, some of the best times for all of us. A lot of work, but it was a lot of good work, and we got a lot of good things done. Just a great bunch of people for me to work with. Such a wonderful organization, and you did such a great job of working with everybody. Always look forward to coming in and talking to you about special questions and special problems, and always enjoyed working with you on any of the pediatric cases. It's just been a wonderful thing for me, and a great pleasure to have worked with you and to have known you. Best wishes always to you and your entire family. Thanks so much, Moody.
Leonard said speak into the mic, so I think I can do this. Moody, this has been an extraordinary day. It's taken me back, well, to 75 when we all got here. And it's been very moving, and it's been an enormously wonderful tribute to you. I always used to say that working at Johns Hopkins always made me feel good because I was working with the good guys. I was doing something that was in my small way contributing to a really good effort. And working with you has been really a joy and a privilege. And thank you. It's been real. Thank you.
Hello, Grandpa. I just wanted to say how proud I am to be your son-in-law. It has been an amazing time getting to know you. It was wonderful getting to hear everyone today describe you just as I know you. You're wonderful, you're intelligent, you're smart, you're strong. The best parts of my life are thanks to you. And 4 years ago, you gave me that life back. So thank you, Grandpa. I love you.
Okay. Hi, Grandpa. Hi. We just came to say we're so proud of you, and we may not know much of your medical career, but we do not know your personal life, and you're really awesome.
You are the best grandpa anyone could have ever asked for, and I love you so much.
Love you.
Hi, Dad. I'm so honored to be here today. I love you so much, and growing up, I didn't know really what you did and the impact you had on so many lives, but I do now. I mean, I've known for a while, but it's kind of amazing listening to people talk about what you did, and thank you for being a great dad, because that's the most important part of my life. So thank you. I love you.